documenting common chart errors, they're going to be things like incomplete patient history. And a lot of times those come up in Z codes. But if we don't have, for example, a good patient history, we may not be able to determine from the documentation that the patient actively has cancer, or are they still being treated, or are they in a watching, waiting stance for that because you're not seeing any treatment, but they've got active cancer, or they haven't had any treatment for 10 years, but the code that the clinician picked was active lung cancer. So again, there's several things that we need to do to make sure that we see everything that's needed and it's clear and precise in the documentation, starting with the history. That's usually the PHI. That's usually what's at the top of a chart. Lack of specific details and treatment plans occur often. One of those would be, again, if you want to use cancer, for example, when the person stopped chemo. Does that mean now they're ready for radiation, or are they not going to have radiation? What if the patient has had some type of gastric surgery and they have an ostomy because of some type of severe enteritis or an ulcer that happened, and you can't tell if the patient still has the ostomy or if the ostomy has been put back together. Inconsistent or conflicting data within the chart. That's where you may have documentation that the patient's obese, but they have a BMI of 55. That's morbid obesity. And now we have classes of obesity, and where we want our clinicians to say it's class 1, 2, or 3, as well as have the BMI documented. You can be very inconsistent. Do they have diabetes with a complication, or did they not have the complication? Providers fail to document rationale for services a lot. They just, this is what the patient has, this is what I'm doing for it. Oh, okay, you changed the medication, but you didn't really explain why you changed the medication. Why did you take them off lisinopril and put them on Nadolol? Because the patient had a persistent cough with the lisinopril. They didn't document that. Again, it has to be clear and precise, and it needs to usually be in the AMP. It's best practice to keep it there, although it can be in other parts of the chart.